Too many days in the darkness.
Welcome to Prevention is Cure, brought to you by PREKURE.com, the podcast which brings you the latest in science and practice and challenging mainstream medicine and finding new and exciting ways of having a happier and healthy life. This series is looking specifically at mental health. We've become really concerned about the lack of translation of what science knows into what medicine does. In most societies, including the one I live in, 1 in 5 of us will have a serious mental health problem at some stage. The infrastructure, the practice, the gap between treatment and best practice is massive. This podcast series aims to do something about it. Prevention is Cure. I'm your host, Professor Grant Schofield. Sonya English is the head of our coaching faculty here at PREKURE. And Sonya has a long experience in the medical system as a critical care nurse and intensivist in those systems, training doctors, living on the edge of life and death and seeing both every day. And I think you're going to find her perspective and her stories around using her coaching, but what goes on and how we need to talk more about living and dying are important things to live a long and healthy life. Without further ado, here's Sonya English. Enjoy.
Too many days in the darkness without a glimpse of the light. Running tired and broken and scared, but I swear I'll never give up the fight.
Sonya, you've got a couple of different things you do. One is what you've been doing most of your career, and which is a critical care nurse and working in hospitals and intensive care units. And the second is that you're a lead coach at PREKURE. I just want to sort of talk about these two completely different worlds that you walk in at the moment. Why don't we start with what a critical care nurse does and what your day and life looks like in that setting and what your joys and frustrations are?
Okay, so at the moment I'm a critical care nurse specialist in outreach. So that's almost like a rescue service where I go out onto the wards and I rescue deteriorating patients and start early resuscitation, assess them, form impressions, and then escalate to senior staff, specialists, people around the hospital, bring them back into ICU or to coronary care or the like. So it's quite an involved job. I think the things that I love about it is it's very autonomous. I get to make decisions and I get to time to assess patients as a whole, holistically. Again, it's not a lot of time, but I can see the bigger picture on clients. So I think that's the joy of my job. And what I love about it, it's almost equal to my health coaching job in that it's a preventative focus, preventing organ failure, allowing the time to see the bigger picture, start preventing that organ failure and prevent them coming into ICU or coronary care or the like. So that's the great part about it.
If you come into ICU, what's your chances of leaving again? Well, I mean, you're going to leave, but leaving alive?
The chances really are around your chronic illness, where you started from when you came into the ICU. If you've got a lot of chronic illness, for example, type 2 diabetes, kidney failure, and you've got a lot of those things that are against you, then the chances are very low. If you come in as a healthy and fit person who, eats well, sleeps well, exercises, and you don't have that chronic illness history, you've got a bigger chance.
Okay, that's interesting, isn't it? So you're actually dealing with people that some of who do die and could die at any moment, and many are at the more or less at the natural end of their life, and some people who aren't anywhere near the natural end of their life but have got something that's gone acutely wrong. How does that all play out, and what are your thought processes around that? And
I think it's really important to understand with critical care that we don't admit everybody. We admit those that we can reverse the reversible organ failure, but also return them to a functional quality of life. And that is, I guess, the criteria for admission to ICU. We really, I guess, the Hippocratic oath for clinical staff is to do no harm.
Yep.
So what we need to do is establish their functional health, find out, how far they can walk, can they dress themselves, what can they do normally, and we look at their organ failure under a microscope, we look at all their blood results, their investigations, and we make a decision on, talking to whānau and family and the client on their wishes, where and when we can. Often we're not able and it's last, end of ditch, but what we do from there is make a decision is, can we, with our therapy in ICU, reverse that organ failure with our therapies, and can we then get them to a reasonable quality of life?
Right, so I guess most people, including myself, have this naive thought that if you're really sick, they'll just bang you in ICU anyway, even if you're going off the edge, and that's not the case, right?
It is absolutely not the case. It is really important that we do no harm, and that we don't want to put someone in ICU. It's very invasive, it's painful at times, it's quite distressing, and we don't want to do that harm when we're actually not going to make them any better.
So these are decisions about people living and dying, and something probably we're not really much good at facing in our society.
Yeah.
I know you talk a lot about that. Just want to sort of explore that whole issue a bit more about, how that plays out in a hospital, how it would better play out in a hospital, what distresses you about that?
Well, I think you've really hit the nail on the head, Grant, because this is the piece that really I find the most frustrating and heartbreaking. I think that in Western culture, we do not accept death. It's a reality for all of us. And what I see now in our health system, in our sickness system, is people that are, really suffering with a whole lot of therapies and really haven't had those difficult conversations with their clinicians, with the clinical staff about what is the reality of the trajectory of the rest of their life. And, what is it that they really want if they really knew what was going on. I think
is it not explained to them? They're not aware of it, or they just don't want to hear it? What's going on there?
I think it's a combination of all of those things. I think often at the beginning of diagnosis, people are in shock. They don't hear, and it's not something that is a theme throughout their treatment. I think one of the things that's happened with our health system is that we're very much in silos. People see an oncologist, they then see a renal specialist, and they see a whole lot of specialists, and the right hand doesn't talk to the left. So we don't really know where our patients and clients are in terms of the mental health, psychological connection with what's going on with them. I also think when they come in acutely, physicians are really, really busy, and no one's got the time to have that conversation. But for me, as a critical care nurse and an advanced care practitioner, this is the most important conversation. What are their wishes? What is it they really want? And what understanding do they have?
And do you have those conversations?
I do.
And how does it even start? How do you do it? And how do you...
Yeah. So unfortunately for me, I meet people when they're deteriorating, when their organs are starting to fail, when they're breathless and they're really unwell. I do absolutely have those conversations, and I use curious questions. I ask them, what is it you really want? What is going on for you? What do you know already? And I can tell you, hand on heart, through years of experience here, when people are really sick, when they're actively dying, they know it.
Yeah.
It's almost like the elephant in the room. And I've had so many patients and clients over the years when I've said to them, you're dying. When I'm honest with them, with their families, thank me, hug me and say, I now can get my family from Wellington.
Yeah.
I now can do the things that I need to do to say goodbye to my family. And it's a really difficult conversation, but it's one of the most important conversations I have as a nurse.
And I mean, it's just hard to understand that. And it's just happening daily. Like, how do you do this? And why are you doing it, and why are other people missing it? What's different there?
I think why I'm doing it is because they are dying often, and because years of experience. I've also had advanced care training, And because 25% of the patients I see as a critical care outreach nurse specialist, I'm having this conversation with. This is well documented in the evidence.
Yeah, right.
That response teams, such as myself, have this conversation regularly. It's not something that's not unknown. I think nurses are about caring, we're about compassion, we're about real, and we see patients every day a lot of the time. Clinicians come in, they see them for 5 minutes. For us, we are there with the reality of what's happening. And I think care and health is about being honest, about listening to your clients and asking them, what do you really want?
And what do people say? What are the range of things that people will say to you when they actually realise what's going on and confront that?
I think the range is absolutely full, from absolute shock, from anger, from acceptance, the whole stages of grief.
Yeah.
But I think it's the way that you do it. Finding out what they already know first and where they're at, because often there's gaps in the knowledge, and that's commonly what I find, and it's filling in those gaps. But the question of what concerns you the most, what's most important to you, what do you really want, and then an absolute pregnant pause as far as saying nothing else and being strong enough to hold that space, your patient will feel that, and they will tell you. And there'll be tears, there'll be anger, but they will tell you because someone's given them the space to take control.
And when that you talk about this do not resuscitate, is that an order or an instruction, how that gets put somewhere for everyone to identify when they make that decision? What's happening there and then when someone agrees that that's what they want?
I think there's such a misconception out there on what do not resuscitate means. And the DHB I work in, and many, it's not for 777, or not for, whatever their numbers are.
Yeah.
But I think what people think is that they're not going to get care if they say that. And I really think it's important to understand that that is not true. Not for resus is we're not going to jump on your chest and do CPR and shock you and do all of those things. Now, when you have a cardiac arrest or an arrest in a hospital situation and you've got a lot of chronic disease, the chances of you getting back to where you were are minimal. And it's actually very aggressive, it's messy, it's awful.
Yeah.
And it's really, I don't think, conducive to good outcome. I think when you sign that or you agree to that non-resuscitation order, you're saying, this is what I want. I don't want that, but I do want other cares. And I think advanced care planning conversations that you have with clients is, what is it you want? You might still want antibiotics and treatment. You might still want that chemo, that radiotherapy. But if your heart stops, you're dead. And that's the reality, and you don't want it restarted.
Yeah.
The chances of you having a hypoxic brain injury, an injury without oxygen to your brain, is very high. And I see that in ICU when people are resuscitated, and honestly, it's not pleasant.
So one thing that stuck in my mind from a conversation a couple of years ago was a description of an elderly woman who was at the end of her life, who died, I think you described it as relatively peacefully, in the hospital.
Yes.
And then, and just correct me, I mean, this, you might not recall the exact incident, but then everyone came rushing in and she was resuscitated. And you described that as a terrifying experience for her.
Yeah.
And she was revived, and then she survived for another several days in some pain and discomfort, and then she eventually died. And you, I think, were describing me your frustration and the grief that had caused you. And then, so that's really stuck in my mind because it's not my reality in preventive medicine, because I'm helping healthy people try and keep a healthy diet.
Yeah.
And then I talked to you just before we started this today, and you said, oh, that happens, I don't know, every week or every other day.
Yeah.
Tell me more about that.
I think what happens is we get patients in that have had a long chronic illness and they're at end stage. You know, they're cahexic. They're really, really nutritionally poorly functioning. You know, they've got a poor quality of life. They've been, you know, their career is hospital clinic appointments. That's what they do. You see them, they've got no resus status. You arrive, they're deteriorating, there's no decision, and you have to resuscitate, because if there's no decision, you have to jump on the chest and start CPR. Now, for me, I see that weekly, monthly. I see it a lot. Yeah. And it is heartbreaking, because I know if someone sat down with them and really truly described what the outcome of that would be, what it would look like, and what the options that they have truly are, and had that brave conversation, I know in my heart they wouldn't want it.
I mean, you would say that about yourself, wouldn't you? I'd say that about myself. I think
100%
everyone listening would say that, right? It's like, do you want to die peacefully now, or have a terrifying experience of being resuscitated only to die again shortly after in pain? Like, who's going to choose B, option B there?
Well, they're end-stage disease, and what's really heartbreaking is they truly don't understand that. And again, it's about, they may have had a conversation, but it's not a theme within, you know, their care trajectory, and I worry.
So what can we do as a society and as individuals, with our own families and with ourselves? You talk about this advanced care planning. What does that mean? What is that process?
I think the first thing to say about that is we need to change the culture. We need to have these brave conversations. We need to talk to our families, to our loved ones at all ages. Anything can happen at any time. And advanced care planning is an initiative from the Health Quality and Safety Commission of New Zealand, and in other countries as well. And it's about having the time to talk to your GP or someone you trust in the health professional specialist realm, who will talk to you about if something happened, if you're, you know, heading toward end-stage disease, wherever you're at, what would you really want? What are your wishes? If you couldn't communicate, what would you like from woe to go? You know,
but we don't want to have those. Why don't we want to have those? I don't want to have those. I don't want to. I start talking to Louise, my wife, about death. It's like going to bring it closer or something that's going to cause it. I don't know. That's sort of it's bad luck, or I don't know why. It
seems to be a fear.
Yeah.
A fear that if I talk about it, it might happen, or you know, if that is something that I discuss, it might happen.
Yeah. Again,
it would be a coaching conversation around, you know, what's going on underneath, Grant, which is fascinating. But I think
but I don't. Like, because I look at my dad who's got cancer, and I think Dad really is scared of dying.
Of course.
But I don't actually feel scared of dying at all. I'd rather not die.
No.
I'd rather be alive. Like, that seems like something. But I'm not. I'm in no way scared of it.
Yeah.
But I'm still not having those conversations.
Yeah. And I feel very similar to you, Grant, is that I want a quality over a quantity. I don't want, for me, what I see happening to the patients and clients out there, it is awful. And I think there's this block for, it's not accepted in our culture or in our society to talk about it, and we have to overcome it.
We're actually heading in the other direction, though, do you reckon? Like, it's been interesting with COVID. Now, no one wants to die of COVID, and we don't want to have a burden from that.
No.
But it seems to me that we've almost gone, you know, we're going to avoid that type of death at all costs, regardless of the other quality of life costs and everything. And we're sort of going the other way.
We absolutely are. We're doing everything in our power to preserve life at all costs. And you look at a lot of the people, and I'm not saying all, and I know the evidence is evolving with COVID, but a lot of the people that are getting this are chronically very, very ill. You know, they have a myriad of chronic illnesses and underlying illness, which for some reason isn't mentioned.
Yeah, right. So then that's an important feature as well.
You know, we look at things like HbA1c, you know, their insulin resistance. A lot of these people have high sugary blood. And they've been chronically ill. It's just not recognised, and they don't know they've got it.
That's another interesting. So not talking about infectious disease. Well, I guess it's infectious infectious as well. Surgery,
Yes.
recovery from any invasive procedure in a hospital, like your blood sugar being high is a really unfavourable thing, isn't it?
Of course it is. Yeah.
And that's, again, it's not really discussed much, and it's something we've got quite a lot of control over.
Yeah, it is. What's interesting is that you hear the conversations in the background as a clinician from medical staff, talking about someone that's come in with horrific multi-organ failure and acute illness in ICU, and they've had a high HbA1c for 2 years.
Yeah.
They've had multiple appointments with clinicians, but nothing's changed.
Yeah, right.
Yeah.
Another thing that I want to explore now is you mentioned to me before we started, Grant, I think you'd find it really interesting to follow me around for a 12-hour shift.
Yeah.
I would. I think, first of all, I wouldn't be physically up to it, but second of all,
I think you would.
what do you mean by that? And you talk about the state of our hospital system, and you talk about a sickness system. Just take me through what that shift looks like and feels like, and why it's not as good as you would like. I
think why I say that when I think about it is because we're tasking.
Yeah.
It's a band-aid over problems. We're giving the fluids, giving the antibiotics, fixing the sepsis, but we're not seeing the whole person.
Yeah.
I think it is about putting fires out. I feel like I'm constantly putting fires out. My desire as a critical care outreach nurse is to go deeper than that, and I guess practice with the view to making sure this patient is not going to come back. The reality of that is they all know my name.
Yeah, right.
Oh, you're back, and that the looks on the faces of the staff in the hospital around how short-staffed, how hard it is to keep the chronic illness that's rising under control. And I think that's the view that I want you to see, is that this is a pandemic in and of itself.
Of chronic disease.
Of chronic disease, and people are coming back so often in their acute phase. We're putting a Band-Aid over it, fixing it, doing the resuscitation, and then they're coming back again. We're not fixing the problem.
We're not normalising their blood glucose or sorting their insulin out or whatever.
Yeah. Actually, what we're doing is we're normalising the abnormal.
Yeah, right. Okay, that's an interesting one, isn't it? Normalising the abnormal.
Yeah, so it's not normal to have a chronic HbA1c of 109.
Yeah.
But we are saying, yep, we've fixed you, off you go.
Yeah, you're right now.
Yeah, have your insulin, have your... So normalising the abnormal. And a client's not that aware of how sick they are.
And so the infrastructure to help people learn to eat better or exercise more or do all those things, and the psychological aspects of bringing them to that meeting, where there is that sort of coaching type philosophy, that doesn't exist, right? And
it doesn't.
No.
It doesn't.
Yeah.
Yeah.
And is that what's because you've been more drawn to coaching?
Yes.
And now you're an experienced coach.
Yes.
So tell us about that journey and how you started that, and let's get into a bit of coaching. Let's see the glass half full side of this.
So that's a really good question, because I was a nurse educator in the ICU for many years.
Yep.
And I come from an educator advice, telling people what to do kind of paradigm. But I could see that wasn't making any difference, really. You've got a client that survived a critical illness, multi-organ failure. There were times that were touch and go. They're in this resonant state of, I've survived, I've lived, and that's the time to jump in and get in there with that lifestyle medicine. They're given their medications, a little bit of advice, and off they go.
Yeah.
And in your heart that that's not enough.
Yeah.
And so
because they've still got the exact same chronic illness, and it's actually getting worse.
Exactly, and we're not winning, and we know we'll see them back.
Yeah.
So I guess for me, it was diving deeper on what's really going on for these clients, but also, I guess, giving them back the power.
Yeah.
Because we need people in our community to beat this chronic health pandemic, we need them to be proactive. We need to understand their bodies, be mindful of what's going on, and take control. We take the control away from them in the hospital.
Right.
I want to give it back.
Because if you're coaching, if you're just meeting someone that you know, otherwise, extensively sort of healthy in the community, or at least not sick, then you ask them about what the important things are in their life, then I've never met a person that the top 1 or 2 wasn't their health.
Exactly.
And the health of the people around them. I mean, that's your experience as well?
Oh, 100%.
Yeah.
I mean, health, and I think the people that I see, they realise that even more because they've had a crisis and they've realised, actually, without my health, I have nothing.
Yeah.
So, yes, I do see that very much. But that soon fades.
Yeah. So, but people who haven't heard of health coaching, what does a health coach do? What some of the principles here? How do you teach that? What do you do?
So, a health coach is someone who works with a client to meet them where they are right now. They uncover what are the values and visions. What is it that they want for their health? What are their dreams? What is it that really will keep them healthy and longevity of health?
So you're not starting a conversation with you're too fat, you need to lose some weight. That's not a health coaching starting point.
Yes, it can be. It can be, I want to lose weight.
Oh, no, but you're not telling them they're too fat.
No, the GP's told them, actually.
Well, that's right, yeah.
Actually,
but that doesn't work, does it?
No, and actually I just had a new client recently who literally had that conversation, felt really shameful about it, but was brave enough to contact a health coach myself and say, okay, I've been told I'm too fat. I feel really upset about it. I've been given no advice on what to do, and I saw you advertised.
Right.
Can you help me?
And then so what do? You say, okay, how does the conversation go from there? So
the conversation from there is, what do you really want? What matters the most? What do you see as a vision for your health? So what I do is I think about what am I seeing in front of me now? What it is that really matters? What's their culture? What are their spiritual beliefs and what's their mental well-being in front of me right now? What are their dreams and hopes? And what is their vision for health? What does it look like for them? What is their perception of good health? Because often a client's perception is related to their life experience, their culture. They might have had a really, really awful experience in the health system and they're really quite scared, and that's not uncommon.
Right, or they might have tried various different types of ways
Diets.
to lose weight before, and not only have they've failed for them, they've made things worse in the long run. And so you're asking open-ended questions.
That's right.
You're trying to get them to be engaged in talking, and you're trying to figure out where they are at.
That's right.
And then when you figure that out, you're trying to, when you say meet them where they're at, what do you mean by that?
So what I want to do is give them the power. They're in the driving seat as, this is who I am, this is what's happening for me now, then to look at where they want to be. So as a health coach, they're driving the process. I am just supporting them. I'm asking curious questions to, I guess, increase their awareness of what's really going on for them. I want to go on a journey of discovery with them on, what is it I can do to improve my health? Where is it I want to start? What are the barriers in the way?
Yeah.
And what do I know? What do I need to know? What are the possibilities for me? Yeah. So it's an exploration of what health is, what I can do, what matters, and where I want to go. And I just help move them along.
So tell me about this concept of resonance.
Yes.
What's that about?
Resonance is one of the things we know in health coaching is that emotion drives change. And resonance is that feeling that you get when you're on top of the world. You're feeling really alive and things are going great. And we know humans, life's a struggle. It's not always going to be amazing. You have good days and you have bad days, but a resonant time is when things are amazing. You feel like you're strong, you've got the power to move forward, and you can do things. And one of the techniques we use in coaching is to be curious and drive them into a state of resonance. Ask questions. What gives you joy? What are you most proud of? What gets you up out of bed in the morning? To make contact with their resonance and their positivity. Coaching is all about moving a client positively forward to where it is they want to go.
And then what about the opposite of that, which is this idea of dissonance?
Dissonance is that whole shame that I talked about with the lady that rang me the other day. Her GP had told her she's fat, do something about it, with no thought on what she could do.
I think there's actually data on that, just to interrupt, that when the GP tells someone they're too fat and should do something about it, then on a subsequent visit they're usually a couple of kilos heavier. Whereas if all they did was reframe that and go, how are you feeling about your health? They not even mention weight. They often they may come back lighter. So that's a really interesting idea about harm.
Fascinating, and it's that feeling of shame, feeling of being judged. You know, people are doing things here to me, and I have no control. So we don't want that for our clients. What we want is for them to be self-actualized, to take the lead, be proactive, and one of the ways we do that is with accountability. We find out what their goals are, how they're going to do that, and when they're going to do it, and we champion them.
And so what was an example of someone helping them find their own accountability? How would it work in practice?
So, for example, if someone wanted to make some changes around their nutrition, for example, they only wanted to eat whole real food, nothing in a packet for the week, I would say to them, what are you going to do tomorrow? And they would give me back the detail on what they're going to do. I would say, when are you going to do it? And they're going to give me the detail on when that's going to happen. And so what we're doing is we're creating a picture or a visualization of the actual steps that they're going to take. Before that, we would have talked about resonance and all the other stuff. So that would have been the driver of change. And then I would ask them, how do you want to be held accountable? Or how will I know that you've done it? So that's that whole
Well, those are big questions, right?
They're very big
But
questions.
you haven't just come out with that. You've got to that point through them telling you that's what they want to do.
Yes. So we've got that visual of where they are now in front of me, where they want to be. We've done some work in the middle around awareness.
And they could be texting you back or something going, hey, I've had a good day. And you'll reply, Louise often is getting back texts from people about did this, did that, had a bad day. She'll be texting them. It's so that's a sort of a way of interacting outside of just that formal session as well.
I think it's also important to say, Grant, that change is messy and habit change is not easy. And, you know, you're also working with your clients around their self-talk, about their negative self-talk and trying to deal with that. But also, you know, they're going to have bad days. We're humans. And techniques on how to get back on that track, how to stay with the eyes on that goal.
Oh, okay. So that let's talk about that. Well, first of all, I agree with that. What you do most of the time matters, not what you do all of the time, because it's, you know, as a human, you know, especially in a world that, let's just take diet, in a world that supports junk food, it's actually a pretty big effort to eat healthy and to maintain that 100% of the time is actually virtually impossible. So you talked about that negative self-talk, and what's another concept in health coaching is this idea of the saboteur. What is it? What's that? I actually found this really powerful. And tell us about that, and people can do a little exercise on themselves about that.
So the saboteur, we all have one as humans. We have this voice in our head that almost derails us and says, you can't do that, you're not good enough, you know, you're not going to get that job promotion, you're not going to be able to do that new position that you've got. And it's quite normal. And I think by understanding that, by naming it, by calling it a name and bringing it to the surface in your life and understanding that it's always going to be there, and then developing techniques to, you know, answer that saboteur back and pop it back down where it belongs, then that allows you to not derail yourself and the goals that you have and actually keep moving forward positively.
So is that sort of like the idea? I mean, we've all got all sorts of thoughts going on in our mind the whole time. I'm thinking I could do this. It'd be awesome if I did that. Or I can't do this, or I might do that, or this is bad and this is good. But those thoughts don't define us. They're just thoughts, right? And some of those thoughts, there's a negative voice and some have a positive voice.
That's right.
And you're helping people make a decision about how much they let that define them and what they do about that.
Absolutely. And also being mindful of it being there and not letting it get the better of them. Also can work with positive voices, like talking about, what's confident Sonya going to say? But that is only ever taken from the client's language.
Yeah.
And what the skill is in coaching is really listening to the client's language, allowing them to name the saboteur, but also naming who they want to be. I often hear clients talk about strong Sonya, or use my name for one of another one, but or confident Sonya, or so naming that positive self-talk and tipping the balance on that's the person I'm going to listen to.
All right,
not
so you might give the confident voice strong Sonya, and you just might call the saboteur Fred or something.
Yeah, exactly.
And sort of distance that negative voice from being the thing that defines you. Oh, that's an interesting thing, isn't it?
And coaching is all about moving the client forward positively. So I think that those concepts are absolutely pivotal to them understanding some of the stuff that's underneath everything. That's driving them not to achieve their health goals.
The coaching aspect has now become more powerful for you than doing your intensive care. Has that surprised you?
100% it's surprised me. What is the most surprising thing is 30 years of ICU nursing, and I've always prided myself on being a good communicator with clients in crisis and patients in crisis, and know that I've learnt a lot through pattern recognition of working with people. Front row seat to human tragedy, I'd say, is where I've been in my career. And I think what blew me away when I started coaching is how much I didn't know, and how much I've learnt about humans that has amazed me since I've been a coach. And an example is an old chap that came into hospital a little while back, and he came and he couldn't breathe. He was really distressed. He was in the resus. We got him sort of a little bit of oxygen, and we needed to put him on a little device to help his breathing, to blow open his airways to help him a little bit. And he just wouldn't have it. And using my coaching skills now as a nurse, as an ICU nurse, the first thing, my priority is airway, breathing, circulation. Get the device on.
Yeah, well, you want him to be breathing. It's not going to end well otherwise. Right.
But my coaching head went to him, held his hand, and said, "What's concerning you the most?"
Yeah.
My cat. My cat at home. Someone's got to get to my cat.
Oh, poor old.
No.
I know, but it's a thing.
I know,
I get it.
and I was like, what's most important?
Yeah.
So we managed to sort his cat out, and guess what?
Yeah.
We got the airway and the breathing sorted.
Yeah.
Now, that's a really powerful example of, and this, I'm going round the wards now.
Yeah.
And I'm saying to the patient, what's most important to you right now?
Yeah.
What I've been doing in my practice is what's most important to me is getting your blinking blue lips red again.
Yeah, right.
Or, you've got no circulating volume to take oxygen to your brain, you're confused.
Yeah.
Say to the family, what do you think is most important here? And they've got the answer.
Yeah.
So I think it's allowed me to listen.
What an interesting situation. You're in the emergency room and it's like, hang on, everyone, stop. We need to get the cat sorted.
Yep.
And it's a real thing.
It's a real thing. So this is about the person in front of you is not just physical health.
Yeah.
It's spiritual, it's mental, it's family.
Yeah.
Family is an important part, whānau.
Yeah.
And it is mental health. And I think this is where we've dropped the ball. I think we're just seeing the physical. We're just seeing the medications, the plaster, treat the symptoms. We're just not... We've lost the holistic frame on working with our patients and clients.
Oh, let's talk about mental health then.
Yeah.
If you're happy to do that.
Of course I am.
And, you've been trained in that as well.
Yes.
You've spent your life looking at different things. Like New Zealand, like every other Western country and many developing countries, has this mental health crisis at the mild to moderate end. All age groups, especially our young people, seem to be prone to this. It wasn't a thing. It hasn't been a thing. It is a thing now.
Sure is.
And then we have this more severe crisis. And what do you make of all that?
Oh, look, it's so scary, Grant. I worry, like yourself, about it. And I think it is, again, another pandemic of But it seems to be...
As parents ourselves as well, of kids that age.
Absolutely.
Yeah.
You hear these words, resilience, anxiety, stress, bandied around the place.
Yeah.
But it's actually real.
Yeah.
And particularly in the mild to moderate, levels of anxiety, of burnout, another word that's bandied around, and stress. And we know in lifestyle medicine that stress is bad for you. It causes inflammation. It causes that chemical imbalance. So I think this is something that we really need to focus on in our mental first aid within acute primary healthcare. And it's just not happening.
So what do you mean by mental first aid?
What I mean by mental first aid is really working with people to take a holistic approach.
Yeah.
Again, those simple questions and providing real support and real, I guess, tools.
Yeah.
It would be like a mental first aid kit. We have a physical one.
Yeah.
You know, it's very well known, but we don't have a mental one. We don't have answers for people. We'll say you're stressed, but we give you no tools.
So it's interesting, you look at the best practice guidelines for mild to moderate mood problems, which includes anxiety and depression in this country. They're very clear.
Yeah.
They're very well written, and they say very clearly that medications are never first-line treatments. They're last resort treatment, and then there's a whole list of interventions, getting fitter, more exercise, eating better, sleeping better, connecting with others, talk therapies, and it goes on. What's the reality?
The reality that is not mentioned in an acute sector where I work, and there's no time. There's no experts in that within the healthcare system.
Including primary care often.
Yeah,
Not always. But
no.
Yeah.
No. And you look at the people like, the physiotherapists, the occupational health, all of those people, they're working with the acute problem.
Yeah.
They're working with the end of the cliff stuff.
Yeah.
There's no holistic approach or toolkit to mental health.
Right, and you see health coaching there as well, right?
I absolutely 100% do. I mean, what has been so clear to me doing this health coaching is there is so much need. But what's even more prevalent to me is the health professionals themselves.
Yeah.
They're the role models.
Yeah.
They are burnt out. They need that mental health toolkit.
That's for themselves as well.
They do. And I think, start at the beginning.
Yeah. So, as we're preparing for this thing that stuck in my mind, we talked about another type of intensive care patient that was a result of mental health issues that often ended with overdoses.
Yes.
Tell me about that type of, because that's a totally different thing, right?
Yeah. So,
and that's actually a fair proportion of people.
Yes, we see, we see a regular amount of people coming in sort of end stage and that, end stage mental illness, and that they've overdosed. It's a massive cry for help.
It's a suicide attempt.
It's a suicide attempt. Most of those patients make it to hospital, not all of them. And we know that it's a real problem in New Zealand. It's been very well advertised in the media of late.
Yeah.
I think that what I've seen over the years is we fix the medical problem, the physical problem. We get a referral off to the specialist, to the psychiatric team, the liaison team. They're popped out on the ward. They have an hour or so interview. A decision is made whether they need to go into a facility in the community or not.
And most often not, because there's not even space for that.
There is a waiting list as long as your arm, and that's it.
And if you look back at their medical history before they arrive with an overdose, what do you see?
Oh my goodness. I see trauma, I see post-traumatic stress, I see often poverty, I see relationship issues, I see multiple admissions, I see, cries for help, I see monthly clinic meetings, I see also do not show. And, there's a whole psychology. Why are they not showing? I think there's a lot of judgment and assumption made on people by health professionals, by community. There's a lot of shame. And I think it's just so broken.
And so part of your view, I guess, then, is that if we, like, these, we're getting at ICU with an attempt to take your own life is like like it's not just at the bottom of the cliff. It's like a massive cliff.
It is.
And we saw them walking along the trail towards that cliff years ago.
Exactly.
And did nothing about it.
Yeah. If you were to take the notes and what we see on the computer and the concerto notes and look and put it on a graph, it's almost, you can see it. You know, it's a trend.
Yeah.
But again, we're not. No one's taking the time to do that.
Yeah.
And what's interesting as health professionals is we see that all the time.
Yeah.
We know the trends, we know the story, but we're still at the bottom of the cliff.
How does it feel when this is like a youngish person still potentially full of life?
Yeah. Oh, it's, you know, it's so devastating, but it's just as devastating to know that I can only put a plaster on this. I haven't got the time to do something real about it.
Yeah.
But what I also know is that small, simple things like one question, you know, one piece of advice around something they could try that's real can make a massive difference. And, you know, like there are simple tools that we could put in place. We just need the buy-in. We need the buy-in from, you know, those management, the people that have the, you know, pen pushers, I guess, so for want of a better word. But it's all about data.
Yeah.
You know, that's how health is run, on data and proof of patient outcome.
Yeah.
But that's not where the money's going.
I mean, you talk about this quite calmly.
Yeah.
For someone who's not facing this daily, it's pretty confronting, frankly.
Yeah, I can see that.
So I'm just sort of going, wow, you know, like, I mean, it's like you don't think of that. You don't think that there's people having to help here at this end and looking back and going, well, this is coming. And we could have stopped and what do we do now? You don't think of that.
That's the very definition, Grant, of compassion. You know, empathy is putting yourself in someone's shoes. Compassion is putting yourself in someone's shoes, but actually doing something about it. And that's what we need across the board in the healthcare system, is some people. And we have people out there doing that. Dr. Glenn Davies, for example. Dr. Lily Fraser. They are not only talking about it, but they're doing it. And that gives me hope.
That takes some courage though, right?
Oh my God, because, you know, the judgment, the assumption that they will have is huge, and yet they're doing it anyway. And I guess that gives me a great hope that will have a trickle effect and that will improve. That for me is the essence of what needs to happen. It's hope.
Yeah, and it's interesting, for some reason yesterday I Googled the medical model in Wikipedia.
Oh yes, what did you find?
Well, it's quite clear that the medical model is one which, you know, is defined by a system which treats symptoms and problems and doesn't seek a solution to them not happening in the first place. Like why are we doing that again? Like, how's that a thing?
It's post-World War II. It's never changed.
And why? What do you mean by that?
What I mean is we had a health system that was really defined by post-World War II. It was a sickness system. You know, it fixed the problems.
And we had a lot of problems.
Yes. And we've never moved from that. And I think we look at almost... If we look at coaching, for example, it's based on positive psychology. We look at what are people's strengths, you know, what can they actually do? What are their resources? You know, what creativity do they have? And we push them, forward from that on their own agenda, The sickness system still looks at the negative frame, what they don't have, you know, their symptoms, what they need, what we can do for them. So it's not empowering the person to move forward, it's just fixing them.
What sort of reinvestment would we need?
A reinvestment in primary care prevention, reinvestment in thinking about mental well-being, spiritual well-being, family, whānau well-being as a whole. Te whare tapa whā. The Māori model has got it all there.
There's already 4 posts of...
There's 4 posts of the whare, You know, it's there. People are learning it in nursing school. They're learning it in medical school, but it's not being applied. So I think the theory's there, it's applying it.
All right, I think we're going to wrap it up. Thank you.
Thank you.
Sonya, that's really powerful stuff. I think the one thing that I had never occurred to me is health coaching in an emergency room, and it turns out to be the old guy's worried about his cat, and it makes so much sense.
Yeah.
Doesn't
Do you know that health coaching for me has changed my life?
Yeah.
In so many ways. I can't even begin to tell you, Grant, but I think what it's done is it's restored my faith that I can make a change, and that how amazing people are.
Yeah. They want it. The power's there, right?
Yeah, they have the power, and we just make so much judgment on them.
Yeah, right.
And actually, they can do far more than we give them credit for. Yeah.
You've been listening to Prevention is Cure, brought to you by PREKURE.com, with me, Professor Grant Schofield. At PREKURE, we're developing a way to help medicine help change the world. We're filling that gap. We're helping train health coaches and mental health coaches. We're bringing short but effective behaviour change programs over 29 days to you to help you learn for yourself and help others as well be healthier. We're trying to create a community of like-minded people like you who want to use the latest science and practice to change lives for the better. Join us at PREKURE.com. Get involved in our communities. We'd love to have you along for the ride. PREKURE.com.
Too many days in the darkness without a glimpse of the light. Running tired and broken and scared, but I swear I'll never give up the fight.